Welcome back. I hope you all had a wonderful lunch. We're going to go ahead and get our afternoon started. Next up, we have Dr. Sam Shahpar. He is a physiatrist currently leading the cancer rehab program at Shirley Ryan AbilityLab. He has extensive experience in the assessing and treating of cancer survivors of all diagnoses throughout their continuum of care, including individuals with chordoma. Today, he's going to talk about physiatry and rehabilitation. Thank you.
Thank you. Hopefully everyone had a good lunch and we don't get too much napping just yet post-meal. I have a lot of slides. I think the slide detail may be a little less important than hopefully getting some feedback and answers from the crowd. I want to leave some time for questions. One thing, usually I've given similar talks to different organizations of varying cancer types at facilities and otherwise, and the one thing I've realized is a lot of people don't know about what I do, including even my own family. They're like, what do you do again? And what exactly is this? And most people think I spell psychiatry wrong or podiatry wrong, or that I'm a physical therapist or whatever the case is. And so education is a lot of what we do, and I really focus on what we do is we are teachers, we're coaches. And I think that's an idea of anyone in the medical field. I actually don't get anyone better. I say that really. I help someone else try to guide their way to the path of recovery. So much different than someone coming in getting chemo. You sit there, you get an infusion, or I think I saw Dr. Walensky here. He's going to come get you on the operating table and kind of take out the physical tumor. A lot of parts with rehab, yes, we'll work and develop a plan, but the work comes from the patient and their team. And so I always think of the patients more as players or students, and we're the teachers and coaches. You could be the best teacher in the world, but without the engaged team that you have or students, the teaching doesn't go anywhere. And so a lot of what you need to do is education to understand why, not just get it done. So the parts that I want to focus on is understand what we do as a specialist, describe some functional issues that can affect individuals with chordoma, and then kind of discuss, this is the other part that we can kind of brush through depending on time, or really about the comprehensive nature of what we do, of what we call cancer rehabilitation. So a few just general slides. Physical medicine rehabilitation is the formal specialty. That is what I'm boarded in. We are called physiatrists. Again, that's that word you saw in the beginning. We focus on the prevention, diagnosis, treatment, and rehabilitation of disorders that produce temporary or permanent functional impairment. A simple way, we're function doctors. We see people who may have cancer. Some of my colleagues specialize in pediatrics, may see children with cerebral palsy or other related injuries. One of my colleagues is right now in France. She is the team physician for the women's national soccer team. So functional issues come in all different shapes and sizes, ages, depending on where they are. And it may be you were born with it, it may be due to an accident, it may be due to a medical issue, it may be that you want to peak your performance as an athlete. But it's all about function, so you're optimizing function given the circumstances. And we address the whole patient because function isn't about necessarily an arm or a leg or a spine or a brain. All those have to work together versus a specific organ system. For instance, a cardiologist is really focused on the heart. The heart is actually really important with rehab, but it's not just the heart, and I'm not just looking at the blood pressure and other aspects. We kind of integrate them together. And really it's about restoring function, improving quality of life, and really anything that affects function is the fair way to understand it. The goal is to provide medical care in order to maximize physical, psychological, social, and vocational potential. That's return to work. And we are trained in general medical practice. I prescribe medicines just like every other MD or DO, but we are also specifically trained in how to guide therapeutic exercise. One thing I teach the students and the trainees that they come through when they write a prescription, if anyone's ever had an infection before, most times their doctors don't just write antibiotics, and they go to the pharmacy and just fill antibiotics. There has to be a very specific antibiotic, a specific dose, a specific course to work. If you just get antibiotics, there's a good chance your infection may not get cleared. It has to be very focused. And actually, a lot of the times when people fail rehabilitation or they didn't work, you may not have had the right plan. There are some things that are resistant and tough to fix, but you can always work with someone. But it's really important that it's not just I did therapy as a part of the rehabilitation plan. The idea is, what did you do? Similar to just like any other medicine. I take a blood pressure medicine. You say, my blood pressure can't be responding. Well, maybe it was the wrong medicine for you, depending on what was going on. And so the idea is activity, therapy, function, exercise needs to be molded to what the individual needs to in order to get the main big outcome that you're looking for. I am based here out of Chicago. I've been here for about 15 years. Some people that may be local or not. I am not breaking HIPAA laws. These are all off the internet, not personal photos. This first picture was Senator Kirk, was a senator based out of Illinois, had a stroke, came and had rehabilitation. I'm going to gauge some of the audience age. I am not the oldest one here, and where it's a similar age group. That is Superman, right? So Christopher Reeve had a spinal cord injury of the cervical spine and had rehabilitation. The Christopher Reeve Foundation is well known about, but he had a physiatrist and underwent rehabilitation. A few other people here, that is Gabby Giffords, who's now, I think, has been a little bit more in the news, but she was the congresswoman that had a traumatic brain injury, and that was her rehabilitation. She was down in Texas. And then Jesse was actually one of our patients here between Northwestern and we are now Shirley Ryan, but it's the Rehab Institute of Chicago. He had the first bionic arm. So one of my mentors, Dr. Todd Keikin, he gives like TED Talks and they do all these cool things of attach wires to muscles. And he was able to control basically that more primitive now than those new prosthetics look way different, but with the muscles, and we have different controls that we do. That is all under our specialty. So we see people with amputation, spinal cord injuries, traumatic brain injury, stroke, sports, musculoskeletal injuries, pain syndromes, cardiac, and including cancer, which Chordoma is part of. I'm going to do some background numbers. I think everyone in the audience probably knows this, but it just helps gauge perspective a little bit to some of the obstacles that you may see in the rehabilitation or accessing rehabilitation. I am going to preemptively thank almost all the data I'm getting is either directly or indirectly related to the Chordoma Foundation because they are the main group that's probably providing most of the info. There are some scattered other studies, but so really references, all credit to the team here. But only 3% of all bone tumors, they are 20% of primary spinal tumors. If you really look at the incidence annually, you're going to see most likely the people here are part of a very special group, which sometimes will make it seem like you won't be able to find someone that knows what's going on with you. In many cases, that's true. I'm going to frame, no matter where you are, that hopefully you can be an advocate for yourself to try to access, or at least know where you potentially can try to access care from a rehabilitation end. Men greater than women, and it is the most common tumor of the sacrum and the cervical spine. I think I'm going to talk a little bit more about anatomy as the tumors of the chordoma breaks down. The skull base you're talking about up near your head. The mobile spine is really in between the head and the sacrum, really your pelvis, but majority of them are on that lower aspect. That's important to us as I see someone who may or may not have a chordoma, depending on where they are in their treatment, that I'm probably going to already thinking the areas that they may be at risk for that may be affecting how their function is. Obviously, the presenting symptoms, you're more likely going to have symptoms related to a cervical spine if that's where the tumor is. So location of the tumor really determines what you're going to end up seeing. Again, I'm going to reference their slides. There's a 2014 data analysis from a community survey looking at over 350 chordoma patients and caregivers. One of the most reported challenges are long-term disability. And so disability is a general term because it can mean a lot of different things to a lot of different people, but disability may be disability from work that I can't work again, but disability could be I can't do the things I need to do or I wanted to do prior. And that's where rehab comes in. So it's a big concern for a whole bunch of group. I am going to, these slides, I try to make them a little bit bigger, but I'm going to point to a few of those aspects that are there, just the highlights. According to this survey, chronic pain, difficulty walking, balance impairment, difficulty sitting, and limited mobility. As you see those percentages, those are all between generally 20 and 38%. So a large majority of people had issues related to function. Again, where someone like me would come in. Another survey of 83 skull-based tumors, and they found, based off one of the surveys, that neurological deficits, including sensory deficits, meaning problems with your sensation, bowel and bladder dysfunction, use of pain medication, and requirement for steroids were associated with a worse function component of one of the testing that they ended up doing. Another study here, 2015, looked at 73 patients at one institution and assessed their bowel, bladder, and motor function. What they did find was generally, depending on their level of surgery, they talked about a low surgery, meaning lower down on the sacrum, middle is the middle level, and high was almost the complete sacrectomy. That preoperative, so how you were doing before surgery was really the best predictor of how someone was doing afterwards. I did think this slide was really, really helpful. You're going to see the three areas: bladder, bowel, and motor. If you look at the 0 column, those are the people that had normal functioning. So if you look on the low end, most people that had a lower surgery tended to do better. The 2 is basically someone who was incontinent of bowel and bladder, and then the 2 would be couldn't walk. Everyone could walk, but the people, as we start moving down, most of the normal as the 0, the higher your surgery went up, the more likely you're going to have impairments, which somewhat makes sense. The more the nerves are damaged, the more problems I'm going to have. Another aspect is we focus on function, again, highlighting why someone like me or rehabilitation is needed. 2017, they did a prospective survey, so following 48 patients moving forward of a primary recurrent, and they did a small group, but you end up seeing problems with mobility, somewhat or moderate. About 74% of these patients had some problems with mobility. I'm gonna pause just right there for a moment, because when we talk about problems with mobility, it is a spectrum. And I found that people who are going through a lot, and whether it's a major surgery, chemo, radiation, when you go through a lot, people sometimes minimize when they're having difficulties and don't seek help because they're busy with many of the other things and it's not that bad. So, oh, I have a little limp, or oh, I got to push off, or maybe I use a cane, or maybe I'll wall walk, we talk about in the house, or maybe I catch my foot. But they're managing. That is something potentially you can get help with. It doesn't have to be that I can't walk and I need a wheelchair, or I fall if I don't use my walker, for someone to get help. As I mentioned at the beginning, myself and some of my colleagues, we work with high-performance athletes or musicians. So even people who are at the 99 percentile can still look to improve. So if there's any even small areas, it's worthwhile to get an assessment to see what it can be, and it may be as simple as a brace or a little therapy or giving you exercises, or at the same time, people, I would just teach in our residents, I think the last 8 patients I saw in my clinic, all of them had a cancer of some type. None of them actually had an issue that was a cancer-specific issue due to their tumor. They had a arthritis that might have been exacerbated because they were a little weaker from their cancer treatment. They might have had a rotator cuff issue because they had a pull when they were a little bit more tired, hurt their shoulder. So even though people have tumors of challenging places, you could still have regular things that everyone gets that can impair your function. So you could imagine if your legs are a little weaker, you may be using your arms a little bit more. You may be pulling and pushing weights, and then you may have arm issues. Again, although not chordoma specific related, that is something that affects function. So the way we think is the whole person. I don't say, well, this is a cancer problem, this is a non-cancer problem. We separate those. It's anything that affects function. So even mild problems with mobility can have a big impact on people's lives. More recently, there was a lot of 2024 studies that were out there with the survey that was done, and they looked at quality of life here with the Chordoma Foundation. I think a few big components is physical, emotional, cognitive, and social. 665 survivors. Only 41% of people thought that their needs were met for their physical quality of life challenges. I don't think that's a blame to any one individual, but that tells me when you're almost half of the patients that they surveyed feel like physically they're not getting their quality of life addressed, it doesn't mean that people are asking to be normal or fixed, but even having them addressed, that's a little bit of a challenge. And I think there's multiple ways to approach that. I think this is one in graph form to show a little bit of that 41%, even that second group of 23%, it was access and did not meet my needs. And so sometimes you see someone who may not feel comfortable with what you're presenting with. They say, I've never seen a chordoma patient before. There's only 300 that come every year in the US. So what I want to do is also help you guys advocate to how to get care, because many times you'll get the block and say, I don't see that, I don't know what to do, versus can you work with me to be able to get the support I need versus just kind of getting things thrown at you. And it's really hard. And at places now, I would say our access has been a lot more since we've seen at Northwestern over probably the last 6 years. We're seeing more of the patients, so my experience has improved. But even then, we would get scattered. And how to approach, at our facility, we get people from all over the world. I would say every few months, I see something I've never seen before. I've never even heard of before. It may be something that they don't even have a diagnosis for, that they come, but it doesn't mean we can't do rehabilitation. And I think that's a perspective to take. You don't always necessarily need to know the specifics of all the details, although hopefully the more you get, the better you'll have, and that includes with tumor treatment. But it goes with a start to be able to guide that, to have that presentation. You will not be able to read this slide because it's too small. I couldn't get this pictured. But this is the physical quality of life symptoms that all chordoma survivors mentioned. I'm going to read them to you. The first one was fatigue, then it was pain, then it was numbness or tingling, balance impairment, difficulty walking, sexual dysfunction, bowel and bladder. And those were kind of, in essence, if we take around the top 10. All those are things that I see almost every single day and varying levels for almost all my patients. So despite a colleague of mine that may or may not see chordoma, those are things that most physiatrists or most people that work in rehabilitation will deal with for a mix of their patients. Questions, anything on that as I've moved through? I'm trying to be attentive to time. I am going to probably do a pop quiz after this to do some spinal cord anatomy if people are interested. Really, the sake of these slides is not for you to be an expert on how the spinal cord works. It's really just to show you of how I and most physiatrists or most people thinking rehabilitation assess individuals. So we have to know anatomy. And I can tell you, I didn't really like anatomy when I was in school because it was like reading from a book and you got to memorize these sort of things. And then you'd have these tests where I have to label all this stuff. And then when I see patients and I can see, okay, this is where something problem and this is where I end up seeing and it applies. And all those little colors and those lines talk about tracks. So if you have an injury to your spinal cord, depending on if it's the front, the side, the back, how much, these tracks will control sensation, they'll control what we call the touch, and then proprioception, pain, mobility. And so sometimes depending on where it is, you're going to have an idea of what muscles may be affected. The one on that other side is the one half of the spinal cord, and outside the spinal cord, your nerves come out. So nerves come out of the spinal cord. We have our dorsal root and we have our ventral root, that's the front and the back. If you snip from there, those are oftentimes where we have what we call peripheral nerve injuries. So injuries to the spinal cord itself in the brain is what we call an upper motor neuron injury. Once you leave and get to those other areas, we have a peripheral nerve injury. Those present differently, and we often have to have a different approach in terms of what we expect, in terms of what patients feel, and how they may or may not respond to therapy. So important as we assess that. Other aspects that you end up seeing here, you'll see the top and the bottom. As we move our spinal cord down, it turns into what we call the conus, and then our conus medullaris and our cauda equina. If anyone has ever had an epidural, they often find the area where your spinal cord ends and they're no longer sticking. They can stick that needle in your lower back to numb those nerves. So when someone, for instance, most classically is in labor, that's what they're doing. They're putting numbness near that bottom to numb that area so you're not feeling as bad. We also have some other nerves that come out of the spine that's part of our sympathetic system and our parasympathetic system. Those aren't necessarily those specific levels, although they come to levels, and those are our body's automated responses, and we have these kind of concourses that cover our bowel and our bladder. So as I think about that, again, you don't have to memorize that. That won't be on the quiz today. We think about upper motor neuron and lower motor neuron. So that's the upper is the central nervous system injury, and lower motor neuron is what we see as the peripheral nervous system. And so, for instance, if someone has an injury that affects the bowels, the general term is called neurogenic bowel, and that means you just have a nerve problem with your bowels. It can happen for many reasons, but oftentimes trauma, tumor, injury will be the cause. People with an upper motor neuron bowel will have their tone in their rectal anal sphincter still intact, so it won't be open or loose. They have a reflexive bowel, and usually it's people who have an injury of T12 and above. Lower motor neuron is when you're getting to that lower end of the spine or the spinal cord or the cauda equina or the conus. Those will have a flaccid tone, and it's an areflexive bowel. So as we talk about the reflexes, one of the reflexes we often talk about is the gastrocolic reflex. So that generally is when I eat, my stomach feels full, and it says empty out the bottom to make room for the rest. So when you fill up your stomach, and we go from there. That's why sometimes after a meal, people feel the need to go to the bathroom. When people have a neurogenic bowel, sometimes we use that reflex to help stimulate bowel movement. So we say after you eat, then you get on the toilet or you do what we call your bowel program to use that reflex. The other aspect is what we call an anorectal reflex. That stool in the rectum, so when there's stool down there on the bottom, it stretches, you feel the stretch, and then it causes the sphincter relaxation to allow that stool to come out. So basically your body feels pressure, and that's not something you necessarily control. Although, if we go back to this slide, it does go up to the brain that you can hold it, right? They're generally a normal function neurologic system, you can hold your bowel and bladder. So a little bit of a summary slide of bowel and bladder. You talk about just where that lesion is. So again, where I see a patient, where I see the injury to the spinal cord will help determine of what kind of program I may or may not need to consider or educate the individual on to help manage their bowels. So things that we talk about for upper motor neuron, stool softeners, colace. You can read some studies. People make the argument that colace isn't great, then doesn't really have a lot of great benefit, although I have plenty of patients that rely on that for long term. Motility agents, you may have heard of Senecot. There's commercials for that. Senna is a plant extract and helps stimulate the bowel. We usually talk about taking that a little bit before you're moving. So if you're going to have your bowel movement in the evening time, taking it at noontime may help. And then per rectum, those are things that go up your backside. That kind of activates that anal rectal reflex. So by putting a suppository in enema, an enema will allow expansion of the rectal walls, and then your body will help evacuate. The suppository will dissolve, and that dissolving will cause irritation, and that irritation causes the contraction. And digital stimulation is a similar end. If a finger can be used for digital stimulation, you push against the wall of, in essence, the anal sphincter and the rectum, and that will stimulate like there's a stretch and create that. This can work for intact bowels, but something to consider in terms of as you gauge that program. Lower motor neuron, as I said, the sphincter is not intact. So you're really trying to bulk your stool. If you have it too loose, it's just going to come out. We don't have a sphincter holding it on. Unfortunately, we want to get things moving because if you get too bulk, so you got to find that balance between a bulking agent and senna. And unfortunately, really the treatment of it, if someone has a complete neurogenic bowel, is what we call manual removal, and this, you actually have to take it out. And so if you have really loose stool, it gets really hard to do. I would say the majority of chordoma patients I've seen are rarely a complete injury of any kind. It's usually a mixed picture, although we've seen from both. And so those are the things that when we talk about rehabilitation, when people get back to where their life is going forward, we got to manage our bowel, bladder, and pain are usually the probably top three things. I think the patients that see me in the hospital now, we just talk about the 3 Ps, and I don't even ask them a question. It's pooping, peeing, and pain. Whether you're 2 years old or 102 years old, if your pooping, peeing, or pain is off, it tends not to be a good day. So this is the basis of where you want to start off with outside of walking, right? If your poop and peeing and pain is not controlled, it's going to be tough for you to get up and function. It's going to be tough for you to spend time with your family. It's going to be tough to have a job. It's going to be tough to do anything because you're constantly worried about all those things which can arise throughout the day. Speaking of bladder, again, we talk about a neurogenic bladder, a similar diagram of all the different aspects of things we pay attention to. We have really a system where you have a sphincter, and you have storage, right? When you're relaxing that, you don't want the sphincter to, when this is filling up, you don't want it to just open and it will all come out. So there's a little song and dance that often comes is when this squeezes, the sphincter needs to relax for your pee to come out. Sometimes when you have issues, you can have a DSD, and that's basically when this squeezes, it doesn't relax, or when that relaxes, it's not matching in terms of, so people get incontinence and bladder spasms and all those other aspects that come into play. We do have volitional control. This is where we teach our children about potty training in terms of holding. Oftentimes we feel it and we can hold it and to a certain end. Generally, a normal bladder will feel the urge to void around 200 milliliters. And I think if I'm looking at these bottles, we are about 330 in these water bottles. So usually, probably not that much less than this is when you start feeling it. You can hold it, and you can hold it to a lot more than this. But the urge of a normal functioning bladder can be there. And actually what I tell the patients, if you take this and just put it in your pelvis and you put it there, you can feel where it is. And if you imagine, we see in some patients who have a liter in there, take a liter bottle and just put it right there and imagine having that there. When people have neurologic issues, sometimes they don't feel it. Their body can sense it, but they may not feel it. And so those are the ideas of what you end up doing. If we end up having the size of this bottle, most of your voids you probably want around 300 and 400. Most of us probably throughout the day when we work, probably hold it. You're on a car ride, you're in a plane, we end up doing it. But a normal functioning, healthy bladder, that's what you're looking for. When we have upper motor neuron injuries to the bladder, they can be spastic or hyperreflexive. This is where you talk about the overactive bladders pretty commonly. Lower motor neuron, you kind of have a loose bladder that sometimes you just retain and it just fills up and you never feel and that bladder never contracts. And so all incontinence is not the same. And this happens with bowels as well. I get a lot of patients that say, no, a whole bunch is coming out and it's loose. But if we're overfilled, we will be loose and incontinent. It's not that it's, oh, I'm always emptying. I can tell you many times with bowel and bladder, they've had ones and we do a scan or we do an imaging and they're still full of urine or stool. And so you can't just rely on what's necessarily coming out. You have to actually do an assessment in terms of how they're managing. So we do x-rays for the bowels. We do bladder scans when people are in the hospital to have that assessment. Sometimes actually doing what I'll go through here is catheters. When people come post-operatively, sometimes some of you may have experienced it, you have a Foley catheter in place. That's an indwelling catheter that drains the bladder. Many times when that comes out, people may have difficulties voiding. So if the bladder is not empty, you put in what they call a straight catheter. It's a similar catheter that looks like the Foley, but often a little smaller. You put it in, it drains, and then you take it out. And many times of the patients we see afterwards, they may need this, and as they recover, they mobilize more, get out of bed a little easier, sit on the toilet, use our other muscles, you can empty the bladder a little bit more. Sometimes people do go home with some of these, depending on what their mobility status is and depending on how they're able to empty, but these are managing. You can decrease spasms, increase retention. You can change a whole bunch of different things. As I told about the detrusor contraction, sometimes those meds aren't really great in the injury to the spinal cord or the nerve. Some people who have stimulating the bladder motions, the neurogenic bladder due to an injury to the nerves, whether it's traumatic or tumor, they tend not to respond to those medicines as well. I know bowel and bladder is probably one of the biggest things in the research and that a lot of people have challenges with. Before I move forward, I'm just gauging in terms of the time. Any questions about these presentation part? Okay. Anytime I talk, no matter who I talk to and where I talk, I mention the word deconditioning. It is probably one of the most underdiagnosed aspects of care of most people in society, whether you have cancer or not. It is not just I'm lazy and I don't get up and do enough exercise. It is a cumulative multifactorial phenomenon and results in functional decline in multiple body systems. You can write papers and I can spend 6 hours talking about it, but I'm just going to give you a few. Back in the day when we didn't actually have to get approval to do studies, they often would take military-age men and just be like, let's do some stuff to you and see what happens. And they didn't get any safety approval. So a lot of them, they would take young guys and just put them in there and don't move, we'll leave you in bed for a week and let's see what happens. You can't get up, lights off, we'll see what your body does. With just lack of activity, you can lose 5 to 10% of muscle mass per week. Complete immobility, you use 1 to 3% of strength per day, and in 1 week you can lose them up to 20 to 30%. After 3 weeks of bed rest, your heart rate resting can increase from 10 to 12 beats per minute. There are some studies that do show that 1 contraction a day at maximal strength is enough to prevent this decrease. So the study was actually done for ICU patients where they had people flex their feet down. We call it plantar flexion, so like you're pushing on a gas pedal. So a lot of this is in the ICU that you push down, and they found that people didn't lose as much muscle and strength when they just engaged a little bit. So even though you say, I can't walk and I can't do other things, this idea of mobilization is really, really helpful. A lot of the data now is swinging back from the intensive care units. They call early mobilization programs, and you could probably look it up. And I think Johns Hopkins was probably one of the first ones to engage. They mobilized people on ventilators. So even after surgery, you have a ventilator or machines, you're hooked up. And they found getting people up, even though they're all attached to things, actually got them out of the ICU faster, got them healing faster, and you had better results. As crazy as it sounds, you're like, I'm on a ventilator, how am I supposed to exercise? But even those little aspects. Anyone that knows anyone who's had a heart surgery, open heart, you might have seen the cardiac chair that goes at bedside. That's a chair that looks like a recliner where they sit in, and that's usually the first step of rehab. You sit in the recliner chair, it's a cardiac chair, so you don't sit straight up, it's a little bit reclined, not to put the stress on, but that's the part of mobilization that we know from a cardiac perspective to help things move forward. From a function standpoint, not all muscles atrophy at the same rate. Our proximal leg muscles, LE is lower extremity, and our back extensors atrophy the most, leading to what we call decreased walking endurance and low back pain. We often see transitional movements are challenged too. So that's what we call a sit to stand. Getting up from a chair, getting on and off the toilet, which sometimes are lower. So a lot of people will kind of lean forward or use their arms to push up. One of the number one reasons back pain is one of the number one causes people go to their primary care. Because on a spectrum, as society, we're probably all a little deconditioned. We have muscles of endurance, not muscles of power. That's why the end of the day, probably coming up soon for most of us, we all want to like slump down and we need our lumbar support. Because our core and our back extensor muscles are not strong enough to hold us up, and we get tired and we want to slump forward and we kind of come down. Again, part of deconditioning could be part of a pathologic process. One thing that we do see, especially when people have a tough time moving, is orthostasis. That's the an abnormality of the normal response when we stand up, that our blood pressure is supposed to match us. I'm sure everyone has gotten up too fast at one point and you feel a little dizzy. At some point, this may not respond and you feel dizzy and it doesn't get better, or you pass out. And so just by being in bed, you can become orthostatic. You don't need to have a neurologic issue. I can tell you people with injuries to their nerves and their spinal cord, this is magnified tenfold because there's a problem with your nervous system. And when your nervous system doesn't respond, remember I talked about the parasympathetic and the sympathetic fibers, normally those squeeze to keep the blood pressure up. It may be delayed or not responding. And again, just resting in bed, not having a nerve injury, it may take 3 weeks to 3 months for that to get normalized. Again, something for us to pay attention to as we get people back to function. A few other things: insulin resistance, problems with your breathing, people's pain and anxiety can increase. Again, not because you have a mood disorder, just being isolated and not moving. All those thresholds, every system gets affected, and you can have osteoporosis. For the sake of time, I'm gonna jump through some of these slides that talk about exercise, and we'll go back to it if we got more. But I wanna talk about cancer rehabilitation because that's what I do. So part of the reason I got into cancer rehabilitation or physiatry is I don't have the skill set of the surgeon of Dr. Walensky to be the skilled of that. I am not as smart as Dr. Kuiken to come up with like robotic arms. Hopefully my skill set is to find avenues for people who have normal or abnormal medical problems and to guide them in the road of functional recovery. When I grew up, I knew a bunch of people with cancer, and then every person I talked to. I don't know anyone that doesn't know anyone with cancer. It affects everyone to a varying degree. And the effect on function is quite drastic. Some people can be immobile and can't do anything, and some people you don't even know they're suffering from cancer or the side effects of treatment. But all those people deserve some access to function, or at least guidance of how to get better. And I've found throughout the years that most people don't even know the benefits there. When I started about 15 years ago, there was a small group of us in our national conference, about 12. Now in our group, there's like 500 of us that have an interest in cancer rehabilitation. So I'm hoping as our group gets better, more and more Chordoma patients, regardless of where you are, will have some expertise and knowledge to be able to help guide people through. If not, physiatrists or rehabilitation professionals, hopefully we give them the guidance of based off what you know about your own tumors and your own treatment to be able to help them to say, hey, have you seen anyone with a spinal cord injury? I have a spinal cord injury. They may not have seen a Chordoma patient, right? But functionally, it's an injury to nerves or spinal cord, and they can help guide you from that structure. So we focus on a multidisciplinary approach: physical therapy, occupational therapy, speech therapy. We determine our local expert therapists. We have settings in inpatient, so after surgery, often people come to the hospital and stay there. That's primarily where I work in addition to a clinic. So after surgery, when they just need to get up and get home. We have a day rehab program, and many places have some sort of coordinated outpatient program where it's about a half day, a few days a week, and then there's single service outpatient, and then people get therapy at home. And then obviously the precise therapy programs depends on how we determine what's going on with you medically and functionally. For the sake of time, I'll kind of move through. Most people probably know what a physical therapist is. I think what some people may not access is occupational therapy. And occupational therapists, you might have seen like a hand surgeon if you have carpal tunnel, they work there. But occupational therapists really focus on what we call activities of daily living, and IADLs is instrumental activities of daily living. If you think of ADLs, those are your basic needs like dressing, eating, getting up, washing. IADLs are more like cooking, cleaning. You kind of need to get it done, but you don't need to get it done every single day. So kind of taking care of your life and the other basics. So they really focus on all those other aspects. So a lot of people just say therapy and like, I need to walk or my arm needs to get stronger. But focusing on functional tasks, they can help you with hands and legs and other aspects, but really assessing how you manage that. My leg can get strong, but I still may have difficulties getting in and out of the shower, right? So it's not just a strengthening process, it's figuring out that. People with skull-based tumors, we may deal a little bit more with our speech-language pathologists. We can have issues with communication, swallowing, speech itself, depending on what kind of side effects you may or may not have from the tumor or treatment. Other aspects that we do engage with people is recreational therapy. This isn't just like, let's go and play. Hopefully most people in the room have a hobby or two. Recreation is involved in that. So we have actually a program that works with adapted golf, for instance. We have people in varying levels of spinal cord injuries or brain injuries or amputees that want to golf. That is something that brings them enjoyment. And so we work with our rehab team and the rec therapists and everyone else, and we potentially look at those different activities of how you can still be involved in that. We actually have in some of our fundraisers, and a few of them, if you've looked in the news, they've been on, I think, Today Show and things. We have mouth painters. Our spinal cord injuries of high cervical injuries that can't use their arms, they actually go do painting with their mouth. And our rec therapists help engage that. I'm not saying anyone needs that, but even understanding of how that can help with pain, anxiety, and enjoying life. Vocational counseling, this is probably one of the most important things if I'm looking at the surveys. That's getting back to work. How do I modify work? Can I do the same job? And they often work with our therapists and patients and employers to help figure that out. Depending on insurance, some people may or may not have better support with that. And locations, I can tell you at our day rehab program, we do have return to work protocols depending on what's going on. But that is important for the sake of disability. Most people don't need prosthetists when we're talking about chordoma, but I put them both in. Prosthetist, orthotist, we call it P&O. Prosthetists, prosthetics, or artificial limbs, orthotics, or braces. So usually they are trained in both, so they'll have that expertise, although they may specialize. But bracing is a pretty common thing we do with many of our spinal cord injured patients, regardless of etiology. It could be as simple as a back brace, it could be a knee brace, a foot brace to help you get through a certain time. It doesn't have to be a cast. So the way I think of rehab is we are a team approach. Everyone is focused around there. You're gonna see in that upper right, there's the oncology team. You've probably heard of tumor board. They come and they meet as a team. Rehab, we do the same thing. The best working system for patients and caregivers are having that linking since the Olympics are starting. It's like the crossing of the Olympic rings, right? When our rehab team and the oncology team works well together, we're able to identify functional issues earlier and be able to address them and help hopefully with people with quality of life. I can tell you it is a work in progress. This is one of the things I've been doing a lot. As we build up our expertise and our volume, it's to meet the needs. That is something, but hopefully you guys can advocate for. I can tell you many patients aren't referred to me, they advocate for themselves and somehow get to me. I'm gonna through some assisted devices, durable medical equipment, and adaptive aids. I think this will be the fast, and then I'll be pretty good on time, and then we can go back if we don't have many questions. Ambulatory aids, you guys have all probably seen these. I'm gonna go through the top. One here is a straight cane. That's a normal cane people have seen. That's a quad cane. There's a quad cane that has a large base and a small base quad cane. Those are lost strand crutches, or other known as forearm crutches. Here is what we call a hemi walker. That is a two-wheeled or classic rolling walker, and the one on the bottom corner is a rolling walker or four-wheeled walker. These do not match of, oh, if I have more problems, I get the bigger one. Which is oftentimes people say, I got a walker. And I said, who gave it to you? And they're like, I just needed it. So depending on what's going on, one may be appropriate or not. And it doesn't always mean to get better, I kind of moved through the less and less. You may never use a cane because that may not be appropriate for you. You may never need a walker because a cane or a quad cane may be appropriate for you. And so having that assessment done of what your needs are and how it can help you with mobility. And these are tools to improve independence. I can tell you most people never like using tools. They're like, I don't want to use a walker, I don't want to use a wheelchair. But if we find that to get you moving more, that improves your independence. So it's a tool for independence, not a safety belt to hold you back. Wheelchairs are a similar way. One over here is a classic, probably manual wheelchair. This one in the middle is a tilt in space, so people who have skin and wound issues, sometimes the plastic surgeon's doing the surgery with the neurosurgeon and orthopedic surgeon as they're taking out. We have to keep pressure off our wounds, or surgical sites, we often tilt back. And the other one is a motorized chair. Again, all these should be assessed by a professional in terms of the right fit versus the right use, what you would be appropriate for based off what's going on. I know many people just buy them and they have just a wheelchair they like lug around, but they're uncomfortable in it and it's not very functional. These are probably the ones that when you leave here, if you know anyone, you can probably help them out. Adaptive aids, OTs, focus on this, but it's really tools to help make things easier. One on top is a leg loop, so some people who have problems bending over, that is a hard kind of metal piece throughout the middle, and there's a loop. So if I want to grab my leg, I can reach and pull my foot and help maneuver my leg to position it. I can help it get in and out of a bathtub. I can help it get it back onto the bed. By using my hand, I don't have to bend over, but I loop through. The second one, you can just see there's a hook. There's a smaller hook on those sides that can help grab and pull up things, whether it's pants if you're leaning over or any other things, sheets, anything else. That is a reacher, the one in the middle. That second to last is what it's tough to tell on there now that I keep looking at it, is a long-handled shoehorn. Shoehorns are probably underutilized, and the ones that are too much out there are the ones that are like this big that aren't really helpful because you still have to bend over all the way and still jam it in. So the long-handled shoehorn can help with shoes. You don't need to have cancer or chordoma or anything else to use these. It can help a lot of people. That last one is a long-handled sponge. You can buy all these off Amazon probably for, I don't know with inflation what it is now, but it's probably up there. One of the other pieces I do mention to people is elastic shoelaces. Again, underutilized. You don't have to get them like neon colors like you have kids or nieces or nephews, but you can if you want to spice it up. But really, they look like regular laces, and you can put them in and tie them, and it allows, again, that bending over to be able to have a slide, and you can adjust in terms of that. Again, people who have issues post-operatively with bending and moving and flexibility, these are really helpful things to get you through. And I've found some patients, they just use one of these, and they're like, wow, my day is way easier. Just because you can do something doesn't mean you should do it that way. That's right. And so if you can make a process more efficient, you're going to save energy. And so that quality of life study that I posted that was done by the Chordoma Foundation recently, the number one complaint was fatigue. And so 2 reasons for fatigue if we think about it. One, we start a day with an energy bubble. Either our energy bubble is smaller to begin with, or we're getting bigger chunks of it out. And so most people who have surgery or cancer treatment, we get a decreased energy bubble. And so our job, when we talk about function, is how do I not take big chunks out if I can make things more efficient? A normal walking is the least efficient or the most efficient process. Once I have an abnormality in where I walk, every step is going to take more energy. If I take all the energy out and I'm sweating and huffing and puffing and get my shoes and socks on, well, that's going to take away energy for me to walk and do other things throughout the day. So efficiency is important, going back to walkers and canes. So if I can get you to point A to point B faster and more efficiently, then you have more energy to recover and spend time on other aspects. And environmental aids, shower bench, a ramp, commode with armrests, all those things important. Orthotics, some of you may or may not have seen those. These are what we call AFOs, many different types, ankle foot orthotics for people who have weakness in their legs when they want to stand and have stability. We have things that are a little bit more burdensome in terms of those are KAFOs. The K is knee, ankle, foot orthotic. Some hand splints and just finger splints depending on what's going on. I know we started a little late and I talked fast. I want to make sure we leave some time for questions, and then I can talk if we want. I can go back to some of those exercise slides. Any questions? Go ahead.
I don't want to get too specific.
Yeah.
Had chordoma cervical C3, C4 surgery, and one of my goals was to, I guess, get reconditioned. I was in pretty good shape before, but it's kind of declined. What is it possible to get reconditioned and build it back up? And then also, the second question was, I've seen my first physiatrist within the last 2 or 3 weeks. We didn't touch on a lot of this stuff, but she mentioned an EMG, and I wanted to know what purpose that would serve.
So I can jump with that question first. So the EMG, an EMG is an electromyography test. It often has an NCS with it. That's a nerve conduction study. Those do not actually tell you what's going on with the spinal cord or the brain. What they will tell you is how your peripheral nerves are doing. So for instance, if you had a cervical or a sacral, you remember I showed you where the nerves come out of the spinal cord? You might have heard of the term radiculopathy, a pinched nerve in the neck. Those tests can tell you whether those nerves are damaged, but most likely we know if you've had surgery, they've had some damage. If you follow that test or do the test, they may show signs of reinnervation, meaning are the nerves healing actively? Do we have active denervation? Are we still having impingement or pressure? Could you still have arthritis or something pushing on the nerve? Or we can also see in terms of just where that status is. So if you haven't had an EMG, sometimes it gives you more information to the health and recovery of that nerve, and that also helps with from a prognostic standpoint. So I started with that one because the reconditioning part is there and say, do I have nerves firing in those muscle groups to see if I can get them better? And so sometimes you can do that clinically. Hey, let's do some exercise. Hey, I'm seeing some progress. Let's work on that. Or you can say, hey, I see some on the electrophysiologic end. I think it's worthwhile that we can kind of push in even if we're not seeing that. And we use things like stimulation. Sometimes they can stimulate to kind of fire those nerves up. But like I said, most people with chordomas usually don't have complete injuries. They're incomplete. And so it's a helpful end that sometimes they can look at that process. It is possible to recondition. The very common end, whether you've had a stroke or a spinal cord injury, if there is no signal, rehab has not learned to make a signal come back. If there's a small signal, rehab can show to potentiate that and help stimulate the nerves in the body to allow that to heal. But if there is no signal, for instance, and we're not getting things firing on the EMG, you can't say that's going to come back. Going back to our bionic arm guy, there are evidence if people have a significant spinal cord injury that sometimes they're doing intact nerves and they're doing muscle and nerve transpositions to help improve function. Usually those people are a little bit more severe, but if they have a tough time, for instance, lifting their wrist, they've done surgeries. The plastic surgeons at Northwestern, a lot of places are learning about that. So the amputee knowledge, some of it's coming towards people with spinal cord injuries as well to help stimulate nerve growth and nerve grafting and other things. And that's kind of the cutting edge a little bit as we move forward. Was that helpful?
Yeah.
Okay, yeah. Other questions? In the back?
Some of the information that you skipped over will that be available for us to review somewhere after?
I've shared slides.
We can share your slides if you're good at that.
Yeah, I'm okay. How are we doing? Do you want me to go through them or no, we want to?
Probably just one.
Yeah, that's fine, yeah. So a lot of the slides are based off the exercise data. I can tell you the exercise data doesn't exist for patients with chordoma, but the exercise data has been shown to be applicable to many different cancer types. And so when we're dealing with tumors, breast cancer is probably the most data, but it's shown with colon cancer and brain tumors and lung cancer. There is a process underlying when we talk about tumor health and how our body fights tumors, recurrence, and even prevention. It comes with that exercise. So some of the data that's out there is on those slides. Well, thank you very much.
Thank you.